Paula Johnson, MD, Executive Director, Connors Center for Women's Health and Gender Biology, and Chief of the Division of Women's Health at Brigham and Women's Hospital in Boston. Gender-specific care is very important because if we reflect on where we are today scientifically, it's the era of the potential of the genome, it's the era of quote-unquote, the emergence of personalized medicine. And if we think about sex-specific or gender-specific care, and I just want to be clear, sex is who we are genetically. Women have 2 X chromosomes, men have an X and a Y. And gender is how we are responded to in society because of our sex. But if we think about this era of the potential of science, and we think about the fact that men and women are different biologically, you know, every cell has a sex, and that's the phrase that the Institute of Medicine coined. The potential for the development of science as we think about sex differences is just enormous. What it means when we think about sex differences in health and disease is that men and women differ in every aspect of health and disease, and the potential for discovery here is tremendous. Today, we only are at the very early stages of understanding what some of those differences are from a clinical standpoint, and we really have a long way to go before we fully understand the scientific base for some of those differences. So just to give you an example, if you look at a woman who has heart disease, or blockages in her arteries, or symptoms that make one think she might have blockages in her arteries, we know that those symptoms differ between men and women. Now that's a clinical observation. What we don't know is why we see those differences in symptoms. Then if you do testing in a man or a woman, the qualities of the test, the sensitivity and the specificity, the characteristics of the test differ between men and women. Certain tests are better in women than they are in men. And then very interestingly, when you actually look at the type of disease women have, so what their arteries actually look like, the arteries can look different. And what we begin to understand is that some of the gold standard tests that we've been using for many years that are based on the typical disease that men have may not function as well in women. And so we've had many years of women undergoing these tests and being told that they are actually fine. So today we're in a different place. We understand that there are some of these differences. Some of that knowledge is not as generalized and as widely understood as we need it. What we don't understand is biologically, why do we see those differences? So as you can see, there's this cycle between clinical observation, science, getting the word out, translation of that science to clinical care, and observation once again feeding more science. I wouldn't say that there are specific issues that are unique to women. What I would say is that there are issues that are either more prevalent in women that need to be focused on, and some risks that impact women differently. So for example, if you look at diabetes, for reasons that we don't fully understand, the impact of diabetes on women's heart health seems to be more profound than it is in men. So diabetes will wipe away some of the early protection women have against heart disease, but women will be more likely to die of cardiovascular disease. And then when you layer over that some differences in, for example, across racial and ethnic groups, you see some very stark differences, for example, in African American women compared with white women, with African American women having much higher rates of diabetes and also having much higher rates at a very early age of cardiovascular disease. Another major health problem is depression. Depression is more common in women, And it also seems as though depression may be more linked to the development of further events, further coronary events when women already have heart disease. So once again, differences in the prevalence of disease and then differences potentially in the impact on outcomes in women. There are some newer technologies in the area of cardiology that I think are very exciting for women. So for example, if we look at the fact that women are more likely to lay down plaque in their arteries in a way that it is diffusely laid down as opposed to there being a very discrete blockage in the artery that can be opened up, for example, with a stent. If women have that more diffuse disease more frequently, then it's hard to see with our traditional tests, which is a cardiac catheterization. Newer innovations with things like intravascular ultrasound that allow us to put a tiny ultrasound probe into the artery and look at the artery almost from the inside out. That is a very important development for women in particular. Not that every woman should have it, but for certain women, for example, who might have a positive stress test, they get in the catheterization lab, the traditional test is done and there's no answer, this might be the appropriate next step. Another exciting advancement is the use of small wires that measure flow throughout the artery. If women are more likely to have what we call microvascular disease, disease in the tiny arteries, the small arteries coming off the big ones, once again, that you can't see with our gold standard tests, then once again, for certain women for whom the answer is not totally clear with traditional tests, this may be an option. And this is very important because it allows us to make a diagnosis in an important subpopulation of women. And quite frankly, I think by thinking about women and how they differ, it will help us look at all patients differently. And it's always my belief that by looking at women and looking at the science and translating that science into clinical care, we actually improve the health of everybody because we begin really thinking about what each and every individual needs appropriate to kind of the evidence. Access to care is complicated. There's a part of access that has to do with being insured. There's a part of access that has to do with being able to find the care that you need. And part of access has to do with when you find the care or when you go to your physician or you're in an emergency room, actually being given the care that's indicated, the most appropriate care. So at all 3 points, we really have to think about the impact of one's sex and also how that intersects with one's race. So if we were to think about women, many women are at higher risk, for example, of losing their insurance, especially since more women are dependent, for example, on their spouse's insurance. So if a job is lost, it's a difficult situation. Many more women are employed in a part-time situation in which health insurance is not offered or may not be offered. Once again, an access issue. But then there are times when we actually are insured that women may not actually be able to find the types of care that they need. For example, we know that there are access issues with regard to primary care. That's pretty general, not only for men and women, not only for women, but also for men. But we also know that women are more likely to seek medical care, so that access may be experienced, or lack of access may be experienced more acutely. There are also sorry.
It's okay, take your time, it's totally fine.
There are some categories of health issues for which there are relative shortages of healthcare providers. So for example, in the mental health area, it may be difficult to access the appropriate type of mental health provider. And if we know that, for example, women have higher rates of depression, this may impact access more significantly for women. Another area where there's an emerging shortage is, for example, in mammographers. We all know that, especially over the age of 40, you need to get your yearly mammogram, and for a set of complex reasons, the numbers of physicians, radiologists going into mammography is actually decreasing. So I think women's health can shed a real light onto health areas and providers, adequacy of providers that can really help us to think about our system. There are also very good data that suggest that minority women, especially African American women, are not offered the same types of advanced care that white males may be offered. And this has been shown now in a number of studies, and it's something that we do need to take into account as we work within our health systems to make sure that care is appropriate, but that people who do have significant medical problems are getting the types of care that they need. For women's health in particular, access with regard to insurance coverage is critical. And as we expand coverage, we've done that in the state of Massachusetts. Hopefully we will see that happen throughout the United States. But as we improve coverage for the whole segment of the population that is uncovered, which will absolutely assist women, we also want to make sure that we don't pull back on some of the government and state-sponsored programs such as Medicaid that also are particularly helpful to women. So I think that's one area that is very important. The second is this idea and issue of access and the appropriate number of healthcare providers. So ensuring that we have enough physicians and other providers in the area of primary care, and really changing some of the incentives so that we have incentives for healthcare providers to pursue careers in primary care. And I think, once again, this is very, very important as we think about comprehensive care in everything from prevention to some of the more complicated, complex quaternary care that is absolutely essential in our system. The third is to think about some of the areas that are more specific to women and to make sure that we don't leave these off of the table. So, for example, in the area of reproductive health, there's clearly a lot of controversy in those areas, much to my dismay, but there's pretty good evidence that good family planning services should be really included within a set of preventative services. And to pull those out and make them a political agenda is something that is not in the best interest of women. So I think looking once again at specific areas to women is going to be very important. And then if you look across the lifespan, there are other areas that are important both to women and men, but I think women bear some of the greater burden. So, for example, longer-term care, what happens to the elderly? What happens to caregivers? The majority of people providing care in their homes to either ill parents or ill spouses or children are in fact women. We know that this takes a tremendous impact on their own health. So how do we begin to think about comprehensive health services that include the care of caregivers, and then work policies that also help to support caregivers? So there are a number of issues across the spectrum, across the lifespan, that are very important. And lastly, there's another one that I think is frequently left off of the table, which is the health of young women. We tend to think about women's health almost beginning at the time of childbirth. So very good policies to cover women who are pregnant with the next generation. But in fact, we do relatively poorly with regard to low birth weight deliveries compared to other countries, and for sure for where we are in terms of our level of income. And I think there's emerging data that really suggests to improve those numbers, we have to improve the health of young women before they're even thinking about pregnancy. So comprehensive, integrated, preventative care for our young female population is critical, not only for their health, but quite frankly, for the health of our next generation. Addressing women's health globally is also something that is critically important. And although it gets addressed in particular ways, really creating a very powerful movement to lift the health of women globally can really transform, quite frankly, the health of the world. And Margaret Chan, who's the current head of the World Health Organization, has made such statements, as has others, such as Hillary Clinton. But you know, women around the world are frequently not only left behind with regard to health, especially in the developing world, but health is a very complex issue. It's not only about health and wellness, but it's about one's social status, it's about one's status because she's a woman in society, one's access to education. But if you begin to truly address the health of women and use that as a motivating force and think about how to transform the health of women through the development of health systems, we really can change, I believe, the health of our world. And I would make sure that we include the United States in that thinking. Emerging technology that allows us to access healthcare, to provide information to our healthcare providers in ways that we would never have imagined, will be very powerful tools in the future. And if we think about especially populations that can't get up and easily get to a physician's office or a nurse practitioner's office, these types of technologies that are already out there but are rapidly developing will become even more important. Now, with all of that said, it will be very important as these technologies develop for us to remember that there's a very important component of care, that is about the human interaction and about the relationship, and it's about trust. So that as we advance technologically, which we are advancing, to make sure that we combine that with the human aspects of care. And I think then we will truly have the ability to revolutionize the system.